We'll get.
Hi, Mike.
Hi there. We'll get started in a couple minutes. Just give people time to join. Maybe those in the UK to finish their lunch, and I'm sure others are finishing calls, or rather trying to catch their breath in between calls. So
could you send the link to the WhatsApp group? Someone is can't get the link.
Okay.
The DX, yeah. Thank you.
Peter, can you or FIFA, could you send this to the group? Because I'm juggling a bit. Thanks.
To zaraz Możliwość szuku. The recording. Hello.
Hello.
Good afternoon.
Good afternoon. We're going to get started in just 30 seconds or a minute.
Okay.
In the meantime, if you'd like to introduce yourselves in the chat, and you can see who all is on the call. Okay, let's get started. Just like to welcome everyone to this webinar / discussion on self-testing. This event is being organized by the civil society and community representatives to ACT-A in collaboration with FIND. And we're very pleased to have colleagues from the WHO joining as well. My name is Chase Perfect. I'm a representative in the country support working group of the diagnostic pillar to ACT-A, and I'll be moderating. As I mentioned, actually, before going forward, I just want to highlight that there's interpretation. So I'll change to French for just 2 seconds in case that's useful. Donc, pour les francophones, il y a l'interprétation simultanée et on peut l'accéder en cliquant sur le globe en bas et en choisissant la ligne français. Voilà. Okay. So yeah, thanks everyone for taking time to join us today. And before passing to colleagues for presentations, I was just going to give some brief opening remarks. The format today will have a couple presentations, one from a colleague from FIND and another from a colleague from the WHO. And then we'll have quite a bit of time for both question and answer on those presentations, but also a lot of time to share perspectives and just for general exchange on this issue. So we'll see how long that takes us. We've got an hour. We may end up using all of that, but if we don't, we'll stop once the conversation has been saturated. So Yeah, the point of today's meeting is to talk about self-testing, to brief those who might have questions on self-testing, but also provide an opportunity to share perspectives on self-testing. Before COVID, self-testing emerged as an innovative tool for HIV in recent years. And more recently, we've seen self-testing on hepatitis C follow in those footsteps. As with much for hepatitis C, the lack of funding and political attention makes the path a bit more uphill than for HIV. But that precedent was, let's say, a bit less well known, or the precedent for COVID testing and infectious diseases was a bit more niche before COVID really exploded it into the wider consciousness. In fact, I think with the self-testing, or at least the lateral flow testing, pregnancy tests were often a reference for explaining to people what kind of test are we talking about with COVID self-testing. And now enough people have the reference point of COVID self-testing that I'm sure it will be the reference point going forward. And the issue of COVID self-testing has also, I think, created greater consciousness of the potential tension or the questions that arise with self-testing related to the right to knowledge of one's health status and the public health priority of surveillance. And I think that's something that will probably come up here, something we can talk about. But certainly from the side of communities, the individual's right to know and right to confidentiality must trump the surveillance considerations as a matter of principle. And in practice, we know that it's often a false dichotomy, that self-testing doesn't necessarily need to undermine surveillance considerations. And this is something we can kind of work through in the conversation today. And just for some more perspective, as civil society and community representatives to ACT-A across the pillars, but particularly in the diagnostic pillar, two of our guiding principles have been equity and access. And with testing, I think it's important to qualify access, because access is not merely access to the performance of the test, but it's delivery of actionable results. So I think that's where self-testing can be unique in terms of not only access to the test itself in places where they may be distant from health facilities, but also the turnaround time on those results. Of course, the question of actionable is another important point to discuss, because one important policy question is what actions may be taken with a positive self-test. So this issue of access being actionable results as one definition is, I think, a comprehensive definition. And it's important to realize that if the whole definition is not realized, then whether people have access to testing, it's a matter of interpretation. And I think it's especially important to emphasize for COVID, because the window for action is so small. And perhaps that's a distinction from some of the self-testing for HIV and hepatitis C, where the turnaround time to take action is a bit bigger. For too long, the only action available in response to the test result was isolation. But recently, antivirals have emerged that show reduced morbidity and mortality in certain high-risk populations, but only if administered in the first days of infection. And we can highlight a bit more about that. And just to complete the introduction by highlighting that a challenge for both these priorities, these principles of equity and access, has been, of course, price. This challenge of price and the difficulties it's posed is true both across countries and within countries, and has introduced serious obstacles to equity. And in that context, in terms of price, but also volumes, we've seen an unprecedented degree of politicization and commercialization of testing during COVID. And in both contexts, marginalized populations have suffered the most from that. So I think that an interesting point we can discuss is that self-testing can be a tool to empower access and to potentially empower marginalized populations. But I think it's important to really take that question to its conclusion, to evaluate if the policies are in place and the financial support is in place to ensure that that translates to empowerment of access in certain communities. So with that, I'm going to pass the virtual stage to Elena Ivanova of FIND, who is going to give us a presentation and some background on work that FIND is doing and some larger context on self-testing.
Thanks, Chase. Can you hear me okay?
Yes.
All right, perfect. Let me just share my screen. Do you see it in the right mode, the presentation mode?
Yes.
Okay, perfect. Well, Mia, thanks so much for giving the opportunity to talk a bit about the work that we've started back in 2000, or more than 12 months ago now, and also talk about the current developments and plans for the future, and hopefully discuss together and see your perspective of what should we focus on and what are the most important aspects to collect evidence on, or to pilot the self-testing as a new intervention. I think, Chase, you have covered most of that. This is a history of the self-testing, so I won't repeat that. I just wanted to highlight that the self-testing is not necessarily only when the person is going and buying the test in the pharmacy and doing it at home, like in many high-income countries, that was the most popular model. But with the other types of the self-test, there was many other successful service delivery models established and piloted, and we do know how to use them very well, such as community-based distribution, the distribution at the workplaces, the vendor machines, and the facility-based testing, etc. So again, to stress that self-testing is not necessarily done by the person with no help. It can be also under assisted model when the peer could, the trained peer could help during the self-testing process, and also provide the counseling before and after the testing. And this model has been extremely successful in HIV self-testing, for example. And also to highlight that the self-testing is more than just a test in the pack that has this very tiny instructions for use that are oftentimes difficult to read, but it's more like a package. So on the top of the test itself that comes from the manufacturer, there could be other supporting systems, such as additional printed materials that are specifically adapted for the cultural backgrounds and contexts, and for specific populations as well. Would be some other supporting tools like videos, like web platforms, digital apps, different other materials. Just like that, the self-test is more than a test itself. It's a package. So for our work in self-testing, as I mentioned, that it started early last year, and right from the conceptualization phase, when we first thought about the self-testing, and also this had a numerous discussion within ACTE, different ACTE working groups. It was seemed logical to structure the work around the three distinct pillars. So the technology development, as we do need the affordable and high quality self-test that can be used in the countries, again, A year ago, the soft tests were extremely pricey. The soft tests just started to come into the high income countries, and the price point was completely unacceptable for the any potential use in low and middle income countries. So that was the #1 priority for us, to get the suppliers' commitments to the low price for LMIC without doing any compromise on the quality, of course. Then policy development, there was really little evidence or no evidence from low and middle income countries on related to the COVID soft testing. So there are some key evidence needed to be urgently collected. And that is not only for the international policy development, but also to support in national policy decision making. And then finally, market shaping, and that's all the activities that relate to the demand creation and piloting sustainable supply models and adequate supply models in different service delivery models. So first, to start with the technology development, that was the one of the activity we focused on a lot last year. So there was an open request for proposals, and we received a lot of more than 80 proposals in response to that. And following the review process, we have established, we selected 6 companies. With 4 of them, we have already executed the contractual agreement. So we have announced their commitments publicly in the recent press release. And you can see that we have the commitments for the ex-work price. That means the price from the factory. It does not include shipping costs. It does not include importation taxes and any distribution or any other vending margins. And it's also important to keep in mind, this is the ceiling price. So meaning that depending on the volume, further discounts should be possible. So the price as per our agreements could not, the price from the factory, the ex-work price could not be above these numbers that are shown here, but it can well be below, depending on the negotiations with the company and the volume, which are frequently depends on the volume of the order. We also we've discussed and had the commitments to the maximum distribution margin that the partners will be controlling, and the minimal commitments to with regard to the supply to LMIC, and that is to ensure that should that be a high spike in demand in high income countries, which are more profitable markets for those companies, there is at least a minimal committed supply to low and middle income countries. So that would not affect the availability of the products in low and middle income countries market. So the registration status. So some of those tests are have already registration regulatory approvals, and including stringent regulatory approvals, and most of the professional use versions of the same test have stringent regulatory approvals, and some of them have WHO EUL clearance. So far, none of the self-tests has the WHO EUL clearance, but it's just simply because the WHO EUL process has just started for self-testing, so it's not enough time passed. But we do know that all of these manufacturers are preparing their submissions to WHO EUL. So hopefully we will see more of them with WHO EUL approval soon. So what we will be doing next, and what we are doing now with them, with the established partners, first of all, we are focusing on clinical evaluations in LMIC to understand, to actually being able to report on the real life performance in different countries. So that's what we are working on. And then with some of them, we are also supporting them to expand the manufacturing capacity to be able, so that they are able to fulfill their commitments to supply LMIC markets. And then most importantly, with all of them, we are working on the go-to-market planning and making sure, so the target countries for this go-to-market plans are LMIC only. So we are not going to support them in any way for entering the markets in high-income countries, only for LMIC. Yeah, so that is for the technology development. This is where we stand, and the some a quick wrap up on of the data that we've collected last year on the related to the policy development. So there was a lot of conversations last year about whether the self-testing would be acceptable by people, or whether people would make a right choice after receiving the results of the self-testing. And that triggered us to set up this the survey of values and preferences. That was a mixed method study that included qualitative and quantitative component, meaning that there was a multiple choice questionnaires, but also a more open-ended interviews. I won't go deep into detail on that, because I remember that some time ago my colleague Soniel has given a detailed presentation on that, but just to remind you perhaps that in 8 countries that we have conducted the study in, we've received a very consistent responses that show the high willingness to use the self-test. Absolute majority of the people were very much willing to use the test. But most importantly, there was the more than 90% of people who said that they will self-isolate after receiving positive results. So the survey was anonymous. So we do believe this, we can trust this data. So another piece of research another research that we have conducted last year, and we are wrapping up this year, is the study on the feasibility and acceptability of the self-testing in urban and rural population in Malawi and Zimbabwe. There was the focus of this study was to understand how correctly people from different populations can do the self-test following the instructions we use, and how the results that are receiving the agreement of the results that they are receiving through the self-testing with the results of the professional use test that is performed by the trained healthcare professional, but also to understand their perceptions around the self-testing. So after a person has had a chance to conduct the self-testing, he or she was asked what do they think about the self-test, and would they use it in the future. So what we've seen is the very high usability of the self-test in both urban and rural populations. So we didn't see any major issues with using the test, and the instructions we used were mostly well understood, and the results of the self-testing were consistent with the results of the professional use test. And it's also, we've seen that the self-testing was highly acceptable in this sample population as well. We've heard some important opinions about the need of building the awareness and education, and enhancing the education and information, clear information about COVID, along with the implementation of the self-testing. There is also a number of projects that are being prepared right now that has been by different organizations. They all have been awarded funding through the Joint Fund Unitate call, and we're among the organizations that received funding for the implementation research, not necessarily focusing on self-testing, but really like with a wider scope on test and treat. I'm just showing here the organization that have a portion on the self-testing research in their projects, and a timeline, so that it's currently under the final stages of the preparation, and hopefully the project will kick off during this quarter, and the results will be available somewhere towards the Q4 or end of this year. Very briefly, where these projects are going to happen. So they're across different countries in sub-Saharan Africa, also in India, in Brazil and Philippines, conducted by different partners, and exploring different use cases. So how can the typical questions that are posed in this pilot research is how to use the self-testing efficiently for contract tracing, how to operationalize a serial testing of different populations that are at high risk of getting COVID and also passing that disease to the others. And then also focus on some vulnerable populations like sex workers. So all this research is mostly to answer the two main research questions outlined in WHO guidance, is optimization of the COVID self-testing service delivery models. And also many of them are looking at the innovation with the digital tools that also seems like a promising tool for the to facilitate self-testing and reporting of the results. And very quickly on some other project that FIND is leading and starting this year. So we are currently preparing projects in Brazil, Malaysia, Georgia, and Kenya. Kenya is not here on the slide yet because it was just newly added target country. What I wanted to say very quickly here is that we for this work, we are in the very tight collaboration with the local stakeholders to understand what are the target user segments we should look at. And most importantly, there is a stage of formative research that we are including here before we actually move to the implementation, and that is to ensure actually the community engagement. So the formative research is to understand what are the preferences of the population of where we are going to run the implementation of how. So we want to understand how people in this community see that self-testing be implemented in the most convenient and best way for them. And we do collect a lot of relevant data before we pass to the planning, move to the planning of the implementation. And it's actually been very useful. So for instance, just showing you an example of how that happened in Georgia. So we've before even moving to the designing of the project, we've asked people of how they want to report and where they want to test. So we've collected the opinions of whether people want to test at home or at work, whether they prefer to report through digital app or through other means. So it's actually a lot of useful information that we learned from these surveys, and that's also allows us to plan the implementation project in a more hopefully efficient way. So that's what I wanted to share. That, and happy to answer any question now or later.
Okay, great. Thank you so much, and thanks for the overview of the huge array of work that FIND's engaged in. I'm smiling because it's hard to keep track of in my own head, and I imagine managing that whole workload is quite a challenge. So I'm gonna pass quickly to Sharon Ann, who has a question, and then there are a couple questions in the chat that I believe may be answered or best addressed after the presentation from WHO. So I'll pass quickly to Sharon Ann and then pass to the WHO, and we can come back to questions.
Hey, Chase. So I hope WHO can address my question in terms of timing for pre-qual or emergency use anyway, and then back to FIND in terms of what role ACT-A is playing in brokering to make sure that there's a timely supply. And one is through a sort of workaround so that countries that are reliant on funding from the Global Fund will not be, the Global Fund will not obviously not be able to procure self-tests unless it has that WHO approval. Therefore, because there's been so much time, sorry WHO, but I mean, let's admit it, there's been too much delay in terms of getting approval, getting the guidance out for the self-test. And so now we're facing delay on top of delay. So would like to see ACT-A play a critical role, or some of the partners, in terms of brokering the transfer of supply. So in other words, a workaround. Thanks, Chase.
Thanks, Sharon. And so that question, so Jillian's noted she can touch on that. Yeah, and I think that some of the challenges that you noted with PQ on self-test have also been the case with PQ on the antigen test as well, in the limited number of tests that have been approved and the challenges for procurement with Global Fund or other agency procurement. I'm going to pass to Gillian Sachs of WHO to give a presentation on the guidelines. And just to note that we do want to take questions and encourage questions. And once Gillian has presented, maybe we'll have a better idea of what questions remain, and we can take that conversation forward.
Great. So thanks so much for the invitation to speak today. I'm just going to share my screen. Do I need to swap the display or it's fine?
I think it needs to be enlarged.
Okay. Is that good?
That's good.
Okay, great. So thanks again for the invitation to speak today. I'm Gillian Sachs. I'm a technical officer in WHO headquarters, COVID-19 Health Operations Lab Pillar. And I'll touch on the self-testing guidance that we released last month and try to position it in the broader context of evolving testing strategies. And I'll try to touch on some of the questions that were already noted in the chat. So as noted, we released our guidance on the use of antigen rapid tests for COVID-19 self-testing about a month ago. And this comes off the back of WHO releasing guidance to guide timely and accurate testing for SARS-CoV-2 since the beginning of the pandemic. So I've just noted some of the other helpful recommendations that have already been issued. In addition to setting these policies, we also have been supporting the development of other materials, including an implementation guide on the use of antigen tests, which was created in collaboration with FIND. And then there are 2 open WHO courses on the use of antigen rapid tests. So I think it's important to acknowledge that there are many different drivers of testing strategies, and we continue to need to be quite agile in the way we're approaching testing as part of this pandemic. Obviously, there's evolving epidemiology, there's varying degrees of political will as well as competing priorities. There's changes in perception on the importance and utility of testing amongst implementing stakeholders. There's always issues with funding availability, and we have luckily not as much recently, but especially in the beginning of the pandemic, there were lots of challenges with supply chain for ordering. More recently, the global shipment system has been under quite a lot of strain, and we are seeing that distribution of tests is being impacted. And then obviously, as already been mentioned, regulatory review and approval certainly impacts the way testing is implemented. But be that as it may, we are trying to ensure that we develop policies as well as supportive materials that help countries as they think about how to prioritize testing, who to prioritize for testing, especially when capacity is limited, be that because of funding availability, human resource capacity, etc. So one option in the overall testing arsenal is the use of SARS-CoV-2 antigen detection rapid tests for COVID-19 self-testing. We developed this guidance through a guideline development group, which was comprised of external experts across a range of subject areas who hail from all 6 WHO regions. Those external individuals reviewed evidence and then set the recommendation. So the evidence that they reviewed showed that users can reliably and accurately self-test, that self-testing is acceptable and feasible across all settings in which it was reviewed, and that access to self-testing may reduce inequalities that currently exist in testing access. So based on that, a recommendation was set. This guideline document, similar to other policy that we set, is relevant specifically to policymakers and others who are responsible for planning and implementing SARS-CoV-2 testing, particularly in low and middle income countries. We are working on creating more derivative products that are geared towards the public, but the policy, we don't necessarily expect members of the general population to read and absorb all the details in it, but it is available online. And I want to just highlight that the guidance is meant to be read in conjunction with all of our other guidance, especially the document that we released in October 2021 on the use of antigen rapid tests. At the bottom of this page, I've just put the link to the guideline document itself, as well as 2 web annexes that detail the evidence that was reviewed to set this guidance. So the specific recommendation that was set is that COVID-19 self-testing using SARS-CoV-2 antigen rapid tests should be offered in addition to professionally administered testing services. The goal of setting this recommendation is for it to enable national programs to now consider how to adopt this recommendation and adapt it to their own national context. The guidance itself includes additional information specifically related to human rights, to the epidemiology and how to interpret self-test results, to the evolving context, priorities, and messaging that may want to be considered as self-testing is rolled out as an option, as well as the fact that there are likely to continue to be the emergence of variants, and it's important to keep in mind that the performance of any diagnostic test may be impacted by these variants. We also include information on general considerations for results interpretation, the need for clear information on messaging and where to find supportive service, how to consider different service delivery options, as well as reporting. So just some key points from the guidance. We note that the why, where, and how to use self-testing really does need to be adapted to national priorities, epidemiology, resources, and local context, and should be done with community input. So if self-testing is meant to address individuals who currently are not accessing testing, understanding how to best reach them and set up service delivery systems appropriately is really critical. We really highlight that access to affordable and quality assured rapid tests, including for self-testing, needs to be prioritized. And we expect that self-test kits should meet this existing requirements for professional use antigen RDTs, which would be to be at least 80% sensitive and at least 97% specific when testing among some symptomatic individuals compared to a PCR. Part of our evidence review shows that many of the self-tests that are approved by stringent regulatory authorities have well above 97% specificity, more close to at least 99%, which is helpful. We note that self-testing should always be voluntary, and specifically in certain settings such as schools and workplaces, self-testing costs should not be borne by students or workers and should not be seen as a barrier to accessing these important environments. And then we also note that clear messaging is really needed so that users understand when and how to test, the meaning of their results, and then any recommended or required post-test actions, whether that involves reporting your result or where to seek additional clinical services if you're positive. We do note that self-testing can be considered for both diagnostic as well as screening purposes. So what this means is that in someone who is symptomatic or with recent exposure to SARS-CoV-2, that a positive self-test result should be considered for diagnostic purposes, and this can enable linkage to clinical care and therapeutics where appropriate. For screening purposes, we note that a negative self-test result in someone who doesn't have symptoms and who is not known to have been exposed to SARS-CoV-2 could enable participation in an activity and give that person increased confidence that they're not currently infected with SARS-CoV-2. But we do note that the possibility of false negative results remains. I just wanted to highlight the implementation guide that WHO and FINE previously released on the use of SARS-CoV-2 antigen tests, because many of the principles that are included in this guide apply to the integration of self-testing within overall testing systems. And then I also wanted to call attention to the COVID-19 clinical care pathway. So as Chase mentioned earlier, there are more and more therapeutic options becoming available. Many of the oral antivirals in particular are most impactful within the first 5 days of symptom onset. So ensuring the appropriate use of antigen RDTs either by professionals as well as by individuals can facilitate earlier access to clinical care that can improve people's outcomes. As I noted, we also, in addition to these policy guidance, we try to make more digestible infographics. There are 5 that currently are being adapted that already exist to incorporate self-testing, and those should be released in the coming weeks. And then when we talk about access, so we know that self-testing provides a way for people to test and make personal risk-based decisions that may affect their own health, as well as the health of their families and communities. We really want to highlight that self-testing is an additional option that can expand access to testing services, but is not meant to replace the lab-based system or the professional use antigen rapid testing system. We also note that there is increasing availability of many rapid tests for self-test purposes, but they often are restricted to the private sector, and hence the prices remain out of reach of most, particularly people in low and lower middle income countries. So as mentioned earlier, the WHO emergency use listing procedure has now been opened to include the review of self-tests. I've included the links here that includes the invitation to manufacturers as well as the instructions and requirements. I am not part of our pre-qualification team, but I will briefly note that we really understand the importance of trying to get EUL approved self-tests through our system as quickly as possible. To try to facilitate this, there's 2 abridged assessment procedures that are in place. One is that any test that is already EUL approved for professional point of care use. So there's currently 5 antigen RDTs that are approved. I believe a 6th one should come pretty soon. Those products, if they are equivalent for self-test purposes, meaning they've just been packaged differently, but it's the same test, those tests will undergo an abridged assessment by our EUL team. Similarly, self-tests that have been specifically already approved or authorized by the US FDA, by Health Canada, or by the Australian Therapeutic Goods Administration, TGA, those self-tests will also receive an abridged assessment. So hopefully with these procedures in place and with the clear instructions to the manufacturers, we can have some approved products relatively soon. I know that our pre-qualification team is already engaging with many manufacturers, so we'll keep you posted on any approvals. Before I wrap up, I wanted to note that one source of information that was used in our policy setting was a global survey that was publicly available. We received close to 900 different responses from individuals in well over 100 countries. And we noted through this survey that at least 100 countries globally either already have policies that support the use of self-tests, or they are piloting the use of self-tests, or they are planning to set policy that is supportive of self-testing. But we did note, and our guideline development group particularly noted that this was skewed more in high-income countries than in low and middle-income countries, underscoring the need for WHO to set our recommendations. We noted that the tests were reported to be mostly distributed through pharmacies and retail settings, which is a bit of a challenge because it does mean that self-testing may be available to individuals through their own payment. And we're hoping that with the release of the WHO guidance and then national programs considering how to use self-tests within their testing strategies, that there can be more offering of self-testing through the public sector. We did note that there was high willingness reported to self-test across all 6 WHO regions. And as already highlighted, there are many products available, some of which have very questionable quality or are not really regulated. And so it really highlights our impetus to have EUL approved products. I've just included links here. We now have translations of the guidance in all of the official WHO languages, which may be helpful to some of you on this call. And with that, I'll thank you for your attention and just note, you know, we recognize that we released this guidance at a time when many countries are scaling down their testing programs. And so we do really want to emphasize that testing remains one of the critical aspects of an effective COVID-19 response strategy. And perhaps self-testing can enable programs to think about what testing needs to be remaining within their professional system, and then how to perhaps rely on self-testing to enable individuals to continue to have access to testing, but without perhaps burdening the healthcare system as much. With that, I'm happy to take questions, and I can specifically answer some of the points that were raised in the chat. Quickly, I will note for Global Fund, their quality policy does allow them to procure tests that are approved through other stringent regulatory authorities, as long as there is a WHO policy in place. So now that we set our WHO policy recommending self-testing as an additional testing approach, it does enable Global Fund some ability to consider adding some self-tests that are already approved through other SRAs to their list in the interim while WHO is reviewing EUL applications. I think I saw a bunch of questions in the chat, but I wasn't able to see them as I was talking, so I can start to review them, or perhaps Chase, if you'd like to call out any particular questions, over to you.
Right. Okay. Well, yeah, I'm gonna just follow up on one particular question with regards to the abbreviated or the abridged pathway towards evaluation. I assume that means that they still have to pass through the regular EUL for just broader antigen test approval before then going to self-test. So would it be accurate to say
I'll
that they're
clarify.
abridged?
So if it's a self-test product that's where the manufacturer has already been approved through the professional use, that
Right.
test would be eligible for an abridged procedure. If it's a new self-test or new company that does not have a professional use test that's approved, if it's already been approved by US FDA, Health Canada, or TGA, then it would also be applicable to go through an abridged assessment. If it's a self-test that has not been approved by any of those three, or from a company that does not have a professional point of care test already approved, then they would go through the full EUL procedure. But I will note, in general, the EUL procedure is meant to be relatively rapid. I know we haven't always seen that be the case during this pandemic, but the goal is to review these dossiers and the evidence in them as quickly as possible. So there's no need to apply for a professional use application if that is not the company's intent. Yeah, it's not meant to be a barrier.
Okay. All right. I see Sharon still has her hand up and may want to clarify the question. And then I'd like to invite, after Sharon, I'd like to invite Brooke, because Brooke has to leave quite soon. And then Isatu and Florence, if they want to take the floor to voice their question. So Sharon, and then maybe I'll pass to Brooke for his question or comment as well before getting a response, because if Brooke has to leave, it allows him to.
Hi, thank you for the clarification about the prequel. Jumping on now to national guidelines. So obviously we want to see as quickly as possible the translation of WHO guidance into national policy and implementation. So what is WHO doing on that? What do you know in terms of what countries have done to incorporate self-testing in their national guidelines? And what tools and fora are there going to be regional meetings? You've got a lot of civil society on here who will be engaging government. So need as much support from WHO leading the charge in terms of not being passive. We have experience from WHO that is very proactive in terms of communicating with government, engaging directly, using your country offices, using the regional meetings versus examples of different diseases over the years. All of us, the participants on this call, from being much too passive and not considering it, frankly, their role to engage directly with governments and encourage the rapid uptake. Thanks.
Really great question, Sharon Ann. So we certainly have put out to our WHO representatives that this guidance is out and that there are key actions to incorporate this guidance into existing national policies. And we're working with our regional offices who have the mandate to more closely engage with our country offices and member states. The self-testing guidance was also presented as part of member state briefings that took place shortly after the guidance release. And so we are incorporating self-testing within overall engagement with our member states. I will note that because of where we are in the pandemic, there are also consultations happening to think a little bit more broadly about how SARS-CoV-2 testing and surveillance becomes more integrated with overall respiratory disease management. And part of that will include overall testing strategies. So self-testing as part of a holistic approach to offering testing services. So I think we're trying to be as opportunistic as possible to ensure that self-testing is part of the discussion as countries are planning their kind of post-acute COVID policies. But I think from civil society, it's really important for you all to engage with your national counterparts to advocate for adoption of WHO policy. And if you have suggestions of how we maybe could message some of this in a different way to facilitate access and uptake, we would welcome those suggestions as well.
Thanks. And yeah, just one point to note that I think is interesting when compared to at least the vaccine rollout, that we've seen prioritization of certain populations in the context of vaccine rollouts. But the issue of prioritization of access to diagnostics has not come up as much. Kind of just a question that's been avoided that I think becomes more relevant in the context of the availability of treatment for certain populations who are at greater risk. I just wanted to flag that and say that it's something that's been absent from the conversation. And I don't know how it's come up before in previous conversations about the way to go about prioritizing access to diagnostics for certain at-risk populations. I want to offer the opportunity to Florence or Isatu to ask any questions, make any comments, because they've been active in the chat. And if not, then I'd like to pass to Kenneth. And if Isatu or Florence, you want to intervene, please raise your hand. If anybody else wants to intervene, please raise your hand as well.
Thank you, Chase, and thank you, Gillian, for that insightful presentation. And mine relates to Sharon's point on WHO's role in ensuring that countries integrate this guidance into their country policies. And I would want to share an experience from the malaria malaria rapid diagnostics, where we saw, and it relates to the question of if there are any pre-qualified manufacturers yet. We saw our country, I'm from Uganda, where we're procuring these diagnostics, especially in the private sector, not from WHO pre-qualified suppliers. And the data on treatment was indicating that over 70% of the negative malaria tests were still prescribed an anti-malarial, and we worked retrospectively and realized that it was an issue of confidence and the quality of the tests. And by then, we are not doing any post-market surveillance or post-shipment testing, quality testing. And the only quality control we had was procuring from WHO pre-qualified suppliers. And I'm wondering if WHO will also support in voicing this and ensuring at least countries are procuring from only WHO pre-qualified suppliers. We led this for the malaria, and we are going to do it for COVID test kits. And I'm wondering if there will be a stronger voice this time from WHO. Over to you.
Sure. So just as a reminder, for the COVID-19 diagnostics, none of the tests are going through the full pre-qualification process. They're all going through the EUL, the emergency use listing procedure, which is administered by our pre-qualification team. At this time, there are no WHO EUL approved self-tests yet. Hopefully that will change in the coming weeks and months. There are many products that have applied and are under review since that procedure has been open to self-tests, which happened 1 month ago.
Okay, thank you. Anybody else have any questions or perspectives to share? I see Elena has noted that it would be great to have civil society's opinion on what populations would benefit the most from self-testing and populations that would not have access to testing otherwise. And yeah, I think as I wait for people to raise their hands. I see Jillian has to jump on another meeting. Okay, I'll pass to Peter.
Yeah, thank you very much. My question goes to find I've done a number of work in Sub-Saharan Africa on self-testing, and there was a lot of excitement, and we will be attending the launch of the outcomes of the bi-directional testing in Kenya. Could you just put some highlights on those successes and the community response to bi-directional testing that was done in Kenya by FIDE?
Thanks, Peter. Unfortunately, I was not deeply involved in this project, so it's my other colleagues that are. I'm just scrolling. I don't think they are on the call. So I'm, I just know on a high level. So really not in a good place to comment on that. But I imagine Keke or Paula from our team would be much better positioned to give more insights, but I don't see them on the call.
Thank you, no problem.
Thanks, Peter. So Jillian has to drop off. So it's also reaching the top of the hour, and I know everybody has very tight schedules. So I put my email in the chat if anybody wants to follow up with further questions or provide further perspective, share experiences, highlight priorities or concerns in country. And yeah, I think with the time constraints, we'll wrap up here, and hopefully we can build on this discussion. Hopefully this was informative, and yeah, we can find a way to continue the conversation. We're going to continue to do these monthly briefings on topics related to diagnostics and COVID. So also, if you have any particular topics that you think would be relevant for one of these exchanges, please let me know. And yeah, just to highlight that if you have any questions or perspectives to share with the representatives to the academic diagnostics pillar, don't hesitate to reach out. I'm sorry that we're having to cut this off, and I think there are still some more questions to be had, more conversation to be had, but just trying to stay within the time. All right, thanks so much, and thanks everyone for your time.
Thank you very much, and bye.
I'll be on for a few more minutes if anybody wants to stay on and highlight points that weren't addressed. Follow-up items, if that's okay, Karishma.
Sure, no worries.
And thank you to the interpreters. Okay, well, I'm not seeing any. Oh, hi.
Yeah, sorry, let me ask a more specific question. Do you know for Uganda if there will be sort of product introduction projects for self-test for COVID?
We'd have to ask FIND for that, because I mean, I think most of the projects are being led by or with visibility from FIND's side. So Krishma, I don't know, or Elena, who the point person for asking that question would be.
So I can find out from Elena. I think we do have a demonstration study going on there, so I can find out and get back to you.
Oh, great.
So yeah, maybe if you drop your email in the
Yes,
chat.
I will do that.
Yeah, let me drop my email.
If you can send me an email, Kenneth, my
Yes.
email ID is in the chat.
Okay.
Okay. All right, well, I'm going to drop off. Thanks.
Thank you, Chase.
Thank you.
Have a nice day, everyone.
Yes. Thank you.
Bye-bye.
Bye.
Bye-bye.